happening now and what's the upcoming activities. It has all the details on the agenda, the logistical notes. We have the app that's updated every night to give you more features on it. So make sure to download it and make the full use of it. In case of any questions, you can reach out to me later on. Thank you.
Okay. Do you want to take questions, or it's okay? Okay, so thank you so much. So this session is on public health emergency preparedness, surveillance, outbreak investigation, and response. And we have 4 plenary speakers amongst us who will be giving some lectures on that, after which we'll have some discussions. So without wasting much time, I would like to call the plenary speakers upstage, and then we can start. So Professor Scott McNabb, kindly give a round of applause as he takes the stage. Followed by Dr. Gina Saman. Dr. Gina. Dr. Peter Nsubuga. Round of applause, please. And then Dr. Tyler Potts. Great. So, ladies and gentlemen, our first plenary speaker will be speaking on modernizing global health security to prevent, detect, and respond to public health emergencies. The speaker is, okay. So, just a brief bio on the speaker. So the speaker is a professor, proud to joining the US CDC, EIS, and serving a 2-year residency in the New Orleans. Dr. McNabb worked for Oklahoma State Health Department. Most of his professional efforts focus on serving those in underdeveloped, underserved global settings. Promoted to distinguished consultant in 2005 and nominated for 2005 CDC Charles Shepard Award, he completed the 2004 Senior Executive Services SES Candidate Development Program and certified by the Office of Personnel Management. From 2006 to 2008, he directed the Division of Integrated Surveillance Systems and Services, National Center for Public Health Informatics, CDC. Before retirement from CDC, he was Associate Director for Science, Public Health Informatics, and Technology Program Office, Office of Surveillance, Epidemiology, and Laboratory Services. Now, research professor at Emory University, Rollins School of Public Health, he directed the King Abdullah Fellowship Program and was principal investigator of the exciting New Africa CDC Institute for Workforce Development. Jointly appointed in the Hubert Department of Global Health and the Department of Epidemiology of Emory, he serves as adjunct professor, Department of Epidemiology and Biostatistics, College of Public Health and Health Informatics, King Saud Abin Abdulaziz University of Health Sciences, Kingdom of Saudi Arabia, and the University of Georgia School of Public Health. Ladies and gentlemen, there's a lot about Professor Scott that you can find on the app if you go there. So without wasting much time, I would like to invite our distinguished professor to give his talk. Professor Scott.
Good morning, AFENET. Welcome. I'd like to start out by thanking Simon for his really outstanding leadership and his team also for serving in supporting this amazing meeting. Please join me in acknowledging them. Thank you, Simon, and your team. And I'd like to thank you for your service to your communities, so please give yourself a pat on the back. Thank you so much for what you're doing for the world. I think it's just really quite an honor to be here. I was fortunate to be here in 2018, and look at the time period between that and now, and I'd like to talk about that with you right now. So the title of my presentation is Modernizing Global Health Security to Prevent, Detect, and Respond. Let's see if we can move it forward. You can help me with that on the IT side. Oh, there we go. First of all, I'd like to also acknowledge and thank Dr. Duncan Selby, who's the president of the International Association of National Public Health Institute. He actually wrote the foreword of the book that I'm going to talk with you about, which was just published 2 weeks ago. So I'd like to thank IAMFI for their support, and I've heard in the meeting how important IAMFI is to you as well. The alignment of FETP programs to the National Public Health Institutes is a very, very appropriate strategic plan. All right, let's see if we can get it moving properly. And then I'd like to thank my friend and colleague, Dr. Stella Chungong. Stella and I have known each other for over 25 years. Stella's from Cameroon, as you may know. We thought about and piloted IDSR in Tanzania in 1998, 25 years ago. That's amazing. And she's now at WHO in a very, very important position with WHO, supporting the countries as they move into implementation of the IHR 2005. So I'd like to acknowledge Stella. The book that we conceived and have written and is published by Elsevier is written with Stella and her team and for Stella and her team, for WHO. Okay, and I'd also like to acknowledge right now the team, the section editors. Dr. Chima is one of those. You can see his picture in this portfolio here. A team of leading scientists in this global community. You may recognize other, Marjorie Pollock, who ran ProMed, and also several other key colleagues, Wandi Alemu, many of you may know Wandi, who worked at the WHO Afro, who's a good, close friend as well. And you can see Chima, Dr. Chikwe, who's one of the best leaders that I've seen in a long time, who ran the Nigeria CDC, who is now heading up WHO surveillance activity. So these key leaders, Dr. Taj is there as well, who we heard yesterday. Taj and this leadership team helped put this book together. So I want to thank them and acknowledge them. There were over 100 authors on the book from around the world, very, very representative group of persons. Plus, at Emory, there were 20 students who performed their master's public health theses by doing systematic literature reviews of each one of the chapters. They served as chapter managers and learned really global health working with this expert group of international authors. So this is the first time that we've been able to present and talk about this book, and this is a very appropriate place to present it for the first time. We also, back April 7th, Elsevier conducted a World Health Day podcast. That podcast is still on the internet. You're welcome to watch it, where we talked about the issues and the challenges that each one of us face now as public health officials. So please welcome you to check out the podcast, and we're very honored to support and work with Stella. So as a part of this celebration on World Health Day, April 7th, we put forward this discussion around modernizing the global health security agenda. And you can listen to it at your leisure. I'm happy to send you a link to it if you would like. So let me see if we can get the music on this. Are we able to get the music Sorry, let me go back. I guess not. So part of the challenge here is there's a song called Turn, 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 which is a song that was written by Pete Seeger, who is an American singer back in the late 50s and early 60s. This song was recorded by the Byrds in I think it was 1965. You may not remember the Byrds. But the point of this is that the lyrics of the song is a challenge to each one of us to look at the current situation and to turn, to be able to be open to the current circumstances, to move it forward.
Under heaven, a time to build up, a time to break down, a time to dance, a time to mourn, a time to cast away stones, a time to gather stones together.
2003, I thought, wow, this is great. These IHRs will protect our global
There is a
community.
season,
Since then, we've had 7 public health emergencies.
and a time
and when
to
the
every
current
purpose
pandemic hit the
under
global
heaven.
community, I was shocked. I couldn't believe
A time of love, a time of hate, a time of war, a time of peace, a time you may embrace, a time to refrain from embracing.
That means that you and I need to be open to new circumstances that have evolved and developed
There is a
so that we
season,
can help and protect
turn,
our
turn,
communities.
turn,
This
and
is
a
a time for
time.
us to do that. So let's talk a little bit about the book. And as I mentioned, that 3.5 years ago, in the summer of 2020, I was doing some press announcements, and I realized, man, this is really going to be bad. How can we experience this COVID crisis after doing all the work that we've done to prepare the global community? And for me, it's like looking at holes in a carpet. My grandmother taught me the value of oriental carpets, and it's like seeing holes in the carpet. We've got to fill those holes. That's what our job is. So the book took us 3 years to develop and write. It was designed to try to identify the gaps in the public health fabric and then to repair those gaps. So let's see if we can move forward. Okay, good. So let's talk real quickly about what is. We want to talk about what is, talk about what could be, talk about the steps to get from what is to what could be, talk about the limits, the challenges of reaching that state of global security. The book was designed really to support, written with WHO and for WHO, to prepare WHO to establish a new revision of the international health regulations. That was mentioned. That was going through. The world has changed rapidly. It's very easy for us to understand that. First of all, we have transportation and communication. We got on the plane on Friday afternoon, and we're here Saturday morning. We'll get on the plane this Friday. We'll be back in Atlanta on Sunday morning. It's amazing. I've never seen the airport so crowded and the airlines so challenged. So we can move back and forth. I've gone through 3 passports. I worked in the Kingdom of Saudi Arabia with 2 5-year multi-entry visas. I knew Riyadh better than Atlanta in some ways. That's an amazing feature of our global community now. So we have rapid communication. We also have frequent mass gatherings of people in one space and time, just like here. Of course, we're thinking about the Hajj and Umrah, the World Cup, other large events that happen where people gather together in great numbers. There's a growing immediacy of the interaction between animals and humans. Our colleague, Dr. Chikwe at Morehouse, is a specialist in One Health. One Health is a feature of this conference. One Health must be a goal and implemented in the global community. And of course, WHO is leading that with the 4 C's: communication, coordination, collaboration, and capacity building. Capacity building, right? So we have to be aware of that, not only animals, but also the environment. We have changing climate around the world. We all know that we are experiencing the outcomes of climate change, which are really shocking. We have malaria in the southern part of the United States, Rift Valley fever in California. We have diseases that we've not experienced in a long time in the United States now, and it's challenging to the epidemiologists and the public health officials in the U.S. We also know that we have, these are the threats that we've experienced. We have emerging and re-emerging diseases, mpox. I've heard several presentations today about these new conditions that we all face. I mentioned the challenges in the United States right now. We also have environmental diseases. We have bioterrorism is still a potential risk, although it's sort of, in my mind, fallen down in its strategy, if you will, and its hierarchy, and lifestyle choices. We've talked about, cardiovascular disease, diabetes. These are things that all of us face. So we are looking at changing circumstances, changing threats, and it's my challenge for all of us that we turn, that we think about these in a very positive and thoughtful, strategic manner as public health officials. These have grown over the past decades, and we're seeing that very, very clearly right now. So years ago, we started to ask the question, are we prepared for the next pandemic? That's a question that was asked back in the early 2000s, as I mentioned, which was a stimulation for the creation of the IHR 2005. As I mentioned, the United States finally adopted that in 2007. You know the history of pandemics, the 1918 flu, one of the most widespread catastrophic national disasters in human history. And it's, began in Kansas in the United States, actually. You can see the history. It's very important. When I teach my students, I teach a course called Transforming Public Health Surveillance. I teach it both at Emory, also at Columbia University in New York, and at the University of Georgia. And at the end of the class, I tell the students, please go watch history, learn history, because if you don't know history, it will repeat itself. And so it's very important for our students, the 20s and 30-somethings, to look at history and to learn what happened, why it happened, and how we could potentially prevent this from happening. Influenza killed more people in 1 year than the Black Death killed in a century. So we are experiencing the rise of re-emerging and emerging diseases.
A model of a virus spread through the air like the Spanish flu back in 1918. So here's what would happen. It would spread throughout the world very, very quickly. And you can see there's over 30 million people die from that epidemic.
I'm sorry we didn't have the sound with that. This has basically happened again. So it should challenges me, it should challenge you too. Why has it happened again? And I think it's important now as epidemiologists that we understand and face the circumstances and we deal with them. And the book has attempted to try to lay out a foundation for all of us to think about and to be challenged by it. You think about the outbreaks through the ages, this is common literature now. We know the different circumstances through the course of history, how many people were killed when this occurred, and so forth. And we're seeing an acceleration of the timeline, the number of people impacted, and the outcomes of each one of these pandemics. And as I mentioned, there have been 7 public health emergencies of international concern declared since the implementation of the IHR in 2015. The very first was in 2019 in the United States. 2009 in the United States, and it was H1N1, and one of my EIS classmate, Rich Besser, was the acting director of CDC at the time, and as you know as well, a public health emergency of international concern is only made that decision is only made by the WHO Director General. So national countries and institutes will be reporting to WHO on different circumstances that may be related to a FEHIC using Annex 2 of the IHR. And so you can look at the circumstances of the 7 FEHICs. My team at Emory was fortunate to work in Liberia with AFENET to stand up, if you will, the Liberia FETP program, as well as the Sierra Leone FETP program, and it's wonderful to see some of my friends and colleagues in the audience. And of course, there have been other circumstances that have occurred that we are experiencing right now. So we are, as public health officials and epidemiologists, looking at the history, understanding the circumstances that have led to where we are today. And the 7 FEHICs are an alert signal to us, if you will, about the challenges that we face. And I'd like to talk about those challenges now. So we have to understand the past, obviously, and let's think about the gaps and the impediments that we all experience in our national work. There's an existence of vertical, stovepipe public health systems with subsets of data that are specific to health outcomes, the disease du jour, if you'll let me use that term, and are subpopulation specific that cannot semantically or syntactically interoperate. We're using public health informatics technology. The databases don't communicate with each other and don't understand each other. There's a chapter in our book, chapter 18, called Informatics Savvy Organizations. This is a chapter written by US CDC with University of Washington, which talks about and provides tools for national governments to do a review of the information communication technology architecture in a country level. And that review at a high level then can provide information to national leaders to develop a smarter strategy. Because you know as well as I do, the last 20 years, there has been an evolution of ICT. And national entities not only don't communicate, collaborate, coordinate, but they actually are hampered by the disparities that exist in the ICT architecture. There's insufficient funding and technical expertise. We've mentioned that in this meeting several times. But don't put your finger just on the need for money. We need to think about what are the health systems that need to be strengthened to be able to advocate for the resources. There is a differing information communication technology architecture that exists in a country. 2 years ago, I worked in the country of Armenia to develop a One Health FETP program, veterinarians and medical epidemiologists who are trained by veterinarians and medical epidemiologists. So teaching the country level, high level ministerial officials about One Health, the need to share information and money and resources becomes the one big challenge that we face. There's a concern about confidentiality of the health information. My students are working, they have a debate on Friday. One of the debate questions is, doesn't the health information that belongs to me, isn't it mine? How can someone use my public health information? I have to give it away or I have to sell it? I mean, think about your individual health information and how do we protect the privacy of that? There's very poor interoperability between public health and healthcare data. In the United States, the last position I had at CDC, we were working with a Harvard team to establish what's called the electronic case reporting, taking reportable conditions from the electronic medical record. I thought it was really a cool idea because you have information entered into the electronic health record and just to abstract reportable conditions. But it hasn't really worked very well. We have over something like 250 different proprietary electronic health record systems. And there's lack of communication. And plus, all of the reportable conditions are not going to be seen in a physician's office, especially if we're talking about One Health. So we have to do, and I'm going to challenge you with 2 things. One is think about the architecture and the definition of a public health ecosystem. Public health has a different workflow process than healthcare. It has a different process. So if we think about a different ecosystem, we can serve the public health needs of the epidemiologists who are sitting in front of their computer screen seeing a case of measles here, another case of measles. What does that mean? They have to take action because that's part of their job. We need to think about creating this type of architecture. And we're working now with Amazon, AWS, to think about ductwork for a global public health ecosystem. How do we create a modern way to do public health surveillance? And there are inadequate approaches and tools that exist. It's important for us to see the current gaps and the current limitations. Now, I believe, and I think you would agree with me, that the world is different now, and it's the wrong way or misguided to believe that hoarding of data, hoarding of information, hoarding of messages, and those are different categories, as you know. You've been taught that as field epidemiologists. And also to try to hoard those pieces of public health architecture to try to improve a political or economic position. And I'm going to talk a little bit about what we believe is important for us to move forward in terms of transparency and trust in the global community to be able to identify and detect and to support. We just basically think that this one nation's concern impacts another. We work together, live together. We really need to be thinking about how we collaborate in this way. And I believe that there is a better way. So my challenge to you is to think about the better way. Okay? I think someone's moving this for me, I believe. I think my point is that understanding the way forward is really the challenge that we all face as medical epidemiologists. And that means, first of all, there's an opportunity plus an obligation to help build the global public health community now by providing a thoughtful, thorough, and balanced scientific review and analysis. That means to describe what has gone wrong, how do we fix it so that another pandemic does not happen. And so with Elsevier's support, you know, it's a very good publishing company. They publish The Lancet, Global Lancet. They're a very, very remarkable company. And a commitment to academic and scientific rigor. 3 years ago, we began to work together to describe the background, the analysis, the vision, and practical actions to aid and assist WHO and other policymakers like AFENET to consider how to change and implement existing policies. This book was written to guide global leaders in highlighting necessary prevention measures and to provide training for the public health workforce. Let me ask the question, how many people are under 30 years of age now? Please raise your hand if you're under 30 years old. Not very many. How many people in Africa are under 30 years of age? 70%. 70% of this beautiful and amazing continent are under 30 years old. That's very important for us to consider when we think about doing capacity building, because the future leaders are going to be from that generation, right? We want to capture the voice and experience of frontline experts battling today's greatest public health challenges via case studies. I was fortunate we hosted in Atlanta 2 case study design and development workshops that were hosted in Atlanta, and I met one of our prior students from 2016 course here. It was really wonderful to see our colleagues and fellow students. Those are all published in the Pan-African Medical Journal. I'm sure you're aware of that. We have 2 special issues in the Pan-African Medical Journal of case studies that were developed from your experiences in the field. We want to address the current, if we can go back, please. Address the current vision. Showcase a practical vision of what the world could look like if we address the current shortfalls and prepare better to face the next pandemic. So our first job is to see what's happened in the past and to think about the gaps, right? Let's think about the key factors to strengthen global health security. You're experts just like those of us in this panel. Think about a unified approach to global health security. There's been lots of discussion already in this meeting about synchronization of emergency regimens and preparations and protocols working together with a common value system as well as vision. Reforming emergency preparedness, readiness, response, and monitoring, guidelines, and to gain greater insight into the legal, political, social, and ethical forces that are at play. And an investment in health equity. One of the things that was so surprising to me in the current pandemic, which is another reflection, let me ask the question, how many people here do not have a cell phone on? Anybody here does not have a cell phone? Couple. Okay, there's one. Out of all this group, so everybody here has a mobile phone, pretty much. We'll loan you ours. That's another important feature. You have a mobile phone, everybody in your community likely does too. Let's talk a little bit about internet access in Africa. How many people, what's the latest data on how many individuals in Africa have full-time access to the internet? Anybody know? You want to say, if you've got a microphone? The latest data that I've seen, somewhere around 36 to 40% of Africans have ready access to internet. That means anytime, right? So there's a gap there that's being filled now, access to the internet. There is a gap, the mobile phones. But remember, we're talking about 70% of Africans are under 30. This is the target for us. We also know that there is an international regulatory environment to prevent, detect, and respond, and has observed now the importance of a global point of view. And so the what is of this is it is largely silent regarding the concept of ethics more generally and how to address ethical concerns to public health emergencies, and the what could be. The book describes the what is using a very thoughtful, thorough scientific review, and then describes what could be. Competencies of global health security, effective interagency, multi-sectoral collaboration. This Prezi will be shared with you as well, and we'll be happy to share with you the concepts of the book. We're going to be presenting November 15th in Atlanta at Emory, a big presentation, more thorough about this in the book. Invite every one of you to attend. We have challenges of the responsibility, the national sovereignty that each one of our countries has, and the authority, as well as the national and international agencies that are involved in health security. So this is one area the book covers, and I need to click through here. The next area is a Global One Health to address pandemics, both ecologic and biological challenges in this dynamic planet. The book describes what is, and then the book describes what should be or what could be, and the steps needed to achieve that. Still having troubles of moving forward here. What could be. So you can see what is, what could be, the steps to move to what could be, and the challenges and the gaps. Plus we have case studies. Every chapter has a case study which will help you. Let me ask also, there are people in the audience who participated as authors or editors of the book. If you please raise your hand. Okay. Have several people that are from AFENET that are authors in the book. There are people from IMPANET and other parts of the global community as well. See if we can move forward. So you can look at the what is and the what could be. The third section is the movement of people and things, the challenge of pandemic spread. What is? Travel and transportation, we've talked about that. What could be? So in the book, you'll see what these global leaders have identified as the current situation, the goals that could be accomplished, and the tasks that are needed to meet those goals. Quickly move through this. The next section of the book is the tools and techniques to modernize prevention, detection, and response, the what is and the what could be. And of course, it was my honor and pleasure to conceive and pilot IDSR in 1998 with Stella, Mike Ryan, and our colleague Peter Nsubuka has worked very hard. He was my EIS officer for 1 year when he first came to CDC. It's a real honor to see him. Moving to the best protected global community, what is and what could be. Happy to share this with you so that you can see the details of this. And this is the book. This is the announcement of the next week's presentation that would be happy to share with you. So my challenge then, this is the end of my presentation. Thank you for the time. I'd like to say that in the United States, we are moving into what's called the Data Modernization Initiative, where we look at the silos. We have 120 siloed surveillance systems in the United States that basically don't work together. We have a big challenge in the U.S. The United States was, according to the reviews, one of the most, theoretically, the most protected country from a pandemic. And look what happened. We did probably the worst of any country in the world, which is a real challenge. Why is that the case? So I want to say finally that AFENET, we're very honored to be here. I want to thank Simon again. I was very fortunate, as I mentioned, to meet many of my friends. So I would say, and finally, despite the wars that we have now and the rumors of wars, I want you to be strong. I want you to do the right thing, be humble, kind, and selfless in serving your communities. I'm very proud to work with you alongside of you. Thank you.
Thank you very much, Professor. So another round of applause for Professor. Before we take the next speaker, I would like to invite Dr. Jean Medat Kanku, if he's here. Okay, so Dr. Jean, let's welcome Dr. Jean with a round of applause. Dr. Jean is the FETP Director of Congo Brazzaville. He will be joining me to co-moderate this session. So let's welcome him with a round of applause. Welcome. Great. So we are going to take the next. Are you okay? Okay. No, Mark Saman, Gina Saman. Yes. Okay, so ladies and gentlemen, Dr. Gina Saman is the head of Pandemic Preparedness Global Platforms, Epidemic and Pandemic Preparedness and Prevention Department at the World Health Organization. Dr. Gina is an infectious disease epidemiologist with a career focused on preparedness and resilience for future pandemic through a disease mode of transmission lens. She also leads the global coordination on the global genomic surveillance strategy to pathogens with pandemic and epidemic potential. During COVID-19 pandemic, Dr. Saman established a response unit focusing on country support, technical monitoring and liaison with the United Nations country teams through the United Nations Development Coordination Office. Saman has been working for WHO for over 10 years at the country level, regional, and the headquarters levels. In recent years, Dr. Saman managed the WHO Pandemic Influenza Preparedness, PIP framework partnership contribution for strengthening country capacities. Dr. Saman previously worked and consulted for agencies including USCDC, USAID, DFAT, Australia, IOM, RTI International, and the Australian Department of Health to design or implement disease control initiatives. Her research interests include management of acute respiratory infections and mass gatherings. Ladies and gentlemen, with a round of applause, let's welcome Dr. Saman.
Thank you for the introduction. Colleagues, it's wonderful to be with you. Let me thank AFENET and Simon and the team for the invitation. Let me thank TEFINET, Carl, George, and the team for the incorporation of this important topic on getting prêt. Prêt in French means ready, thank you. So getting ready, get ready for the next pandemic. This is the topic of my presentation. And so let's get started. Lots of lessons from COVID-19, lots of analyses, lots of reviews. We heard from Scott earlier, who really lined up this presentation perfectly, that we need to get better prepared and build on what exists. So preparedness works. Health is everyone's business, this whole of society concept. No one is safe until everyone is safe. So having a population under 30, 70% of the population under 30 on this continent, what does that mean in terms of who's vulnerable? And lastly, that response must be agile and adaptive, and that we're constantly innovating. And I think that was also pointed to in Scott's presentation. So let's take some examples. But before that, let me ask you the question. Colleagues in the room, raise your hand if you think preparedness works. Lots of hands coming up. Is anyone unsure or would answer no to that question? Anyone unsure? I don't see hands. Oh, I do see a couple of hands. Thank you. Thank you for your bravery. It's good to be brave. But here's a great example of where preparedness does work, and it's from this region. At the time of COVID-19, countries had to rapidly set up testing capacity for SARS-CoV-2. And in the region of Africa, countries that participated in influenza virological surveillance systems, GISRs, the Global Influenza Surveillance and Response System, pre-pandemic, significantly faster established SARS-CoV-2 testing capacity. Of the 47 countries that had influenza virological surveillance capacities, these were faster at establishing SARS-CoV-2 testing, i.e., preparedness works. Other examples that are important to point at when we're thinking about the lessons is that innovations and being responsive and agile are important. Who had really heard of infodemics and the need for social digital listening pre-COVID-19? This really erupted as a body of work in our work of risk communications and community engagement. We also had established during COVID-19 these epidemiological investigation protocols, the unity studies, of which many countries in this region had participated. So congratulations. Again, innovations, response being agile and adaptive. So congratulations. Another is on the role of field epidemiologists. So I really appreciate this paper, and I think Kip and some colleagues from the authors of this one are in the room, of 65 programs globally that responded to a survey to say, what did you do during COVID-19? Graduates and trainees had participated in many activities. 98% did something in coordination and leadership, 97% in surveillance and case investigation and rapid response teams, and the list goes on, including in risk communications, monitoring, etc. So we all, us field epidemiologists, we played a role. So my presentation has two themes. One is that we have risks ahead and we have to prepare. And the second is you as field epidemiologists are the superheroes of that response. So we need to be getting ready together. So what I'm going to be talking about is this PRET, a new approach to pandemic planning, taking a mode of transmission approach. And the second theme is around field epidemiologists and our critical role in preparedness. Do we have the skills that are fit for purpose to do the tasks that we did during COVID, and how do we do them better? So, as I mentioned, PRET is this initiative. If you go downstairs to the registration table, you'll see a flyer and a computer sticker. If you'd like these, grab one downstairs. But the new approach is about improving preparedness for groups of pathogens based on how they transmit, based on mode of transmission. It builds in the knowledge, the experience, the initiatives, the approaches that we need in One Health, according to the IHR, and of course as how member states, WHO's countries, agree to move the global agenda forward, the resolutions. This initiative, PRET, this pandemic planning by mode of transmission, was launched in April this year with a call to action to countries. And if I was asked to tell a Minister of Health what is PRET really about, this would be my slide. It's basically saying to plan for the next pandemic, we build preparedness on the foundation of what exists and what we do routinely. So having built that surveillance and testing capacity for influenza, we were ready to surge it and use it and leverage it for COVID-19. We can be risk-based because we can prepare for what we know causes pandemics, and we can then also be ready for a pathogen X. Again, a mode of transmission gives you that flexibility. We can be efficient. We can be collaborative, building on what we learned from COVID-19 and our new modes of interaction. And of course, innovations continue. So, mode of transmission approach, what's our first mode? We're thinking respiratory. So we've developed a module looking at how we plan for pandemics for respiratory pathogens. And so this is available online if you'd like more. And what it does, it sets out the why, the how, the what, and the how. So really trying to organize ourselves operationally. It gives the context, the what we need to do, and how we should go about it. So how should we go about it is critical. And if we all plan in our different countries and our different states and regions in a similar way, that would be useful because it means we can be interoperable, another word that Scott's presentation really emphasized. So we need to have this foundation of resilient communities, multisectoral systems, core capacities. We need to have ongoing surveillance and risk assessments at all levels, bread and butter of a field epidemiologist, right? Then we have to think about the different periods and operational stages as we think about what we're going to do. In the first, during the inter-pandemic period, we're preventing and preparing. Then as something is detected, the emergence or the introduction, those initial cases or clusters, we're responding, and generally we're trying to contain an event. As transmission grows, there's sustained transmission in the community, we're responding to suppress transmission. If it continues with multiple waves and iterations and cycles of transmission, we're more likely going into the mitigation of transmission and the impact, mitigating the impact of that event. And then as the situation stabilizes, as we've seen in COVID this year, we go into recovery to stand down the systems of emergency, but to sustain what we need for managing that disease effectively. And we go back into interpandemic prevention and preparedness for the next one. With PRET, we've identified this multisectoral piece, 15 sectors that have to engage when we think about preparedness. COVID has taught us that we can't go it alone. It also provides an organizing approach by 5 subsystems. How we prepare for these groups of pathogens by subsystems for emergencies. So community protection, which includes border measures, public health and social measures, where the different sectors engage. The other piece of that, of course, is risk communication and community engagement, including infodemic management, clinical care and infection prevention and control, accessing countermeasures, including their development and rollout, emergency coordination, including the financing, the human resources, and the policies and governance around an event, and collaborative surveillance, looking as well at the laboratory systems and the One Health systems needed. All that putting together and seeing where all those IHR core capacities fit in and, of course, form the basis for the work that we do. PRET also provides an outline of how we can structure a pandemic plan. And even though countries may already have an outline or an old pandemic plan that they seek to update, great, use your own, but look at this to see if you've captured elements or it gives you ideas of how to go about planning. As a trainee, this is useful, where you are maybe involved in teams that are developing plans. This may be helpful to help structure your thinking. PRET also provides steps, a process of how to develop or update plans. Again, more details of the how and how we operationalize. And I think this is important as we try to stay and maintain that momentum established. How do we do this together? How do we be interoperable? So there are webinars. You may join online, EpiWin webinars at WHO. There's an online community of practice. You'll see the QR code at the end of the presentation. Please join us. Please tell us about preparedness and what you do. We want to work with you. There's a PRET network for countries to co-develop pandemic plans, a website with lots of resources, a partners forum to engage and share information, and of course meetings and workshops to support countries in the rollout. This we're already seeing. Since the launch of this initiative in April this year, 81 countries by August had conducted workshops, simulation exercises, and other learning workshops to look and start updating their plans. By the end of this year, we actually think 100 countries would have adapted and adopted some of what's going on. So congratulations to countries in this region. You are really zooming ahead. So let me then take you from what we can do on pandemic planning to what you can do in pandemic planning, this important role of field epidemiologists. And as we saw with that initial journal article that I presented earlier, field epidemiologists played a critical role. We have examples where national programs also published their work. We can see examples from Australia, Uganda, Papua New Guinea, and the flavors are similar: surveillance, leadership, management, coordination. And again, another follow-on global piece that was put together that basically said field epidemiologists even got into the operations and logistics, monitoring and evaluation. So as I look at this kaleidoscope of what field epidemiologists need to do during a pandemic, what they did during the pandemic, I now want to think ahead. As a program manager of pandemic planning, how can I be ensuring that field epidemiologists are trained and ready for the next one based on what they did during COVID? So this is where we come to having a PRET workforce, epidemiologists in pandemic planning. And this is where our work with the different programs, the field epi training programs with AFENET and the regional groups such as AFENET and others is critical, because we need to be sure that as programs provide the training, we as programs that use the trainees and the graduates can co-develop and co-have materials and graduates that are competent in this space. So we are participating in the Global Field Epidemiology Partnership to infuse this idea. The other piece that we're doing, and is work in progress, is that we're co-developing curricula with programs on pandemic planning to help prepare the next generation of field epidemiologists to take on this role. And you can see from what's on screen that we've defined the statement of competency, the learning objectives that could be taking place, the methods, a simulation-based approach in group work, and skills gained in both leadership and management, but also those technical competencies that you saw earlier in terms of pandemic planning from a PRET approach. And of course, interested programs from this region, please contact me, please contact Carl or George at AFENET or Simon at AFENET. We'd really like to work with you to see where the opportunities are to help prepare the next generation. This is my last slide. So 2 takeaway messages. As promised, 2 themes discussed in this presentation. Please, as field epidemiologists, plan for a future pandemic recognizing that preparedness improves health security. Use PRET's approach, that mode of transmission thinking, to be efficient, leveraging what exists. And for secondly, for FETP directors or those who are involved in workforce strengthening, field epidemiologists clearly play a critical role in pandemic planning and response. So to ensure that the future generations are ready, they're fit for purpose, consider the competencies, the modules, the alumni ongoing continuing education on pandemic planning. And for that, we're all going to ensure that the superstars of the current and the future are best prepared for the next pandemic. Thank you with that, and back to you, Chair.
Another round of applause. So, ladies and gentlemen, we've listened to 2 presentations so far. We want to take questions on this. The first presentation was by Professor McNabb on modernizing global health security to prevent, detect, and respond to public health emergencies. Professor McNabb drew our attention to emerging and re-emerging diseases. He provided us a little bit of history surrounding that. And he mentioned that we shouldn't watch history. Don't watch history. Learn history. Otherwise, if you don't learn history, history will repeat itself. I hope I got it right. Great. So he also mentioned issues related to capacity building, the need for building capacity and considering our future leaders, and some key factors to strengthen global health security, which include a unified approach to global health security and synchronized response, among others. Our second presenter spoke on WHO preparedness and resilience for emerging threat initiative, PRET. So she mentioned, among other things, that preparedness is very important and that there should be innovations, and also drew our attention to issues related to infodemics, the role of epidemiologists in preparedness, and also emphasized on the WHO's new approach, which is the PRET. Among other things, she mentioned that preparedness should be routinized. We should put preparedness in our routine efforts. And some definitions that she can use to encompass what PRET is about include efficiency, collaboration, and innovation. Finally, she also mentioned that the PRET framework, she described the PRET framework within the concept of the 5 C's, which are collaborative surveillance, countermeasures, community protection, clinical care, and at the center of that is coordination. And the last words were, we should plan for the future as epidemiologists, and for the leaders, they should strengthen field epidemiology capacity in order to achieve PRET. Ladies and gentlemen, if you have any questions, we have 2 microphones on the aisle, so we want you to just stand behind the microphones, and we'll take as many questions as we can, depending on the time that we have. So please bear with us if you are not able to take your questions at the plenary. We have opportunities to discuss outside the plenary. So kindly go ahead.
Carl Reddy, AFENET. Thank you very much, Scott and Gina. Scott, thank you for that panorama that you painted. And your presentation in Prezi is really very, it's very impactful. So a thought crossed my mind as you were speaking, and you did challenge me to ask you a question, right? So in modernizing global health security to respond to public health emergencies, we clearly have seen recent developments, great advances in terms of technology, diagnostics, big data, artificial intelligence, right? At the same time, the world we live in is being characterized more and more by dominance, by inequity, by exclusion, by the blatant trampling of human rights, right? So the question is, how do you ensure people's health security if their human rights are trampled upon? Leading on from that, our FETPs deal with outbreaks, other public health emergencies, natural disasters, humanitarian crises. I mean, we just need to think of the migration crisis in Venezuela, the Ukraine, Palestine, Sudan, Somalia, Yemen, right? So my question is, what are your thoughts on the role of our field epidemiologists? Should they be apolitical, like the Red Cross, right? Or in doing their work in the face of blatant trampling of human rights and abuses, should they advocate for and defend human rights in order to ensure diversity, equity, inclusion, and belonging? It's a bit of an existential question, but you did challenge me.
Thank you, Carl. Thank you very much, Carl. Chapter 2 in the book is a book around ethics, which basically discusses a movement away from the sort of colonialization effort. We all know that one of the biggest challenge we face is about money and power. Right? Money and power are what people are embedded with, so to speak, and we have to move from a point of view of being selfish, where it's all about me. I want you to do this work. You can do it. You can do the work and get my money, so to speak, if you do what I think you should be doing. That's not the correct movement forward. So we talk about working against neocolonialism. We talk about the role and responsibility of thinking about the global community. I believe and I hold that you should speak the truth even if your voice shakes. That means that if you see something that is not right, you should be speaking the truth. That doesn't mean in violence, but it means in describing what the truth is. So I believe that field epidemiologists have several responsibilities. One, in their own individual job and where they're working, to speak the truth, even if your voice shakes. Sometimes it's to your boss. And also we need to move away from neocolonialism. We also need to move away from what I call brain drain. I'm really very much concerned about the fact that people who want to improve their career have to leave their country to get a job after training. That's one of the problems with the FETP program now, is that you're trained, you want to continue to improve your credentials, but you have to go with an international organization or leave your country to get a better job. So identifying the problem, identifying the circumstance, and then moving in the right direction by, in a peaceful way, speaking the truth to power, I think is very important. We have the chapter on ethics was down in the book, and we moved it up to chapter 2 because we thought it was so important that it should be that high in the level of the book. So I'm happy to share that chapter with you, which describes the ethical considerations that we all are trying to deal with right now. These are great, important questions. Thank you. I think that leadership is the other thing. I think that in leadership you learn that the action that you do is to support the other person, not yourself. You're not working to get a better career, to make more money. You're working to help other people have a happier, safer life, right? So moving from selfishness to selflessness is a part of leadership training.
Great. So I think we'll alternate with the question. So the lady first.
Okay. Thank you very much. Lydia Nature, coming from Uganda. My question goes to the presenter who presented about the PRET framework. With a lot of interest, I see a linkage between the efforts that are happening in Uganda. Right now, we have a project that is being piloted in Uganda where we are utilizing strategic risk assessment to be able to identify hazards, and we start preparedness efforts. And this is what we are calling the Enhanced Situation Awareness Project in Uganda. It's a pilot that we are doing with support from Resolve to Save Lives. And in your presentation, I noticed you mentioned just a little bit about using information concerning hazards, but I didn't see the linkage, how you determine the priority hazards, whether it's through utilizing strategic risk assessments, or you have other means that you determine which hazards you prepare for using the PRET framework. Thank you.
Thank you. Excellent question. And congratulations on using the STAR approach. I think it's an excellent approach to exactly define what are your priority hazards. So in many countries that have applied STAR, we're seeing that respiratory pathogens of pandemic potential are one of those evergreen, essential hazards to need to be preparing, responding, and planning for. But there are others, such as the arboviruses, such as potentially foodborne pathogens. And what's great about STAR is that this approach, this analysis approach, brings together different sectors. So, in essence, yes, this is a wonderful approach to determine where to put your resources to plan for the next one. And I think the use of STAR and then following on with steps of pandemic preparedness using PRET, they are actually really quite sequential. So we have a video, a GIF video that talks exactly about that point. Think about your priority hazards, then here's some tools that you can use and some programs and some operational approaches that help you prepare for that next one. So they are linked, absolutely, if only we had more time. So thank you for that comment.
I think the last two questions kindly go straight to the point. We are far behind time. So the last two questions, please, for this session.
Okay. Good morning, everyone. Thank you, Gina and Scott, for those presentations. My question is straight. Considering preparation for the next pandemic, what are your thoughts about AI? Because the world is moving very fast, and we don't seem to be talking about it in public health. The areas where AI is being used in health is usually clinical right now. But I think for field epidemiologists, how do we incorporate AI into the training? Thank you.
Great question. AI is the elephant in the room. And developing what we would call ethical AI is the challenge that we face right now. It can serve us, or we can be hampered by it, so to speak. And we actually have students working on developing concepts and ideas about how do we develop ethical AI. Just think about data entry once. If you are a physician and you're entering information into electronic medical record, you're seeing a patient that has a reportable condition, malaria, TB, whatever. We can create an AI environment within a public health ecosystem where the physician or PA enters the data once into the system, and it goes concurrently into an electronic medical record, but also into a separate public health ecosystem. Because as I mentioned, public health has a different workflow than healthcare. So we can use AI to enhance and empower public health surveillance. But we have to be doing that now. We need to be thinking about what is ethical AI.
Last question.
Thank you so much. My name is Gabra Christos Nagash Gabru. I am the resident advisor for the Sierra Leone Field Primary Training Program. My question and comments goes to the first presenter, Professor Scott. But before I go to my comment, let me use this opportunity for appreciating Professor Scott for supporting the Sierra Leone Field Primary Training Program and also for strengthening the public health system of Sierra Leone. I would like to comment on the research. I see, especially in African countries, there is a disconnection between researchers, policymakers, and public health system implementers. Most of the time, the strategies, public health strategies and policies are not informed by the finding from the research. So how do you think we can narrow the gap between researchers and policymakers?
Thank you.
The second comment is, sorry.
So we are hard pressed with time, so can we take
okay,
one?
So thank you so much. All right, thank you.
For understanding. Great. Thank you.
That's a very, very good observation, and it is a gap right now. I think that, and my opinion is that the field epi training programs should be aligned to the academic institutions in the country. I think there should be also what I'm talking about, building bridges from academic institutions in the United States, in Europe, everywhere, so that we work at Emory in collaborating with academic institutions like in Uganda, wherever there's a school of public health, where training programs are developed and offered, and the field, especially the field epi training program work, is actually in a collaboration of investment. And I believe the FETP should be aligned to the schools of public health, so those that complete the FETP program can be credentialed, have certificates, have an improvement in their career. That doesn't mitigate against the, the need for, boots on the ground, but I think it actually addresses the point that you make. So I think this is a very important area where AFENET could design a strategy. The Africa CDC is working on this as well. It's an excellent question. It's a goal.
Bonjour à tous. Si vous pouvez bien mettre vos casques, parce que la deuxième partie de la modération va se passer en français. Ce n'est pas un coup d'État, hein? C'est une collaboration sud-sud, une complémentarité. On est resté assis pendant longtemps. Est-ce qu'on peut se mettre debout pendant 1 minute? Essayez un peu de se bouger, s'il vous plaît. Merci beaucoup.
Thank you very much. We're going to continue. Like we've just said a few minutes ago, my name is Jean Médard Kankou. I'm an epidemiologist. I'm a doctor in public health. I'm also a researcher in public health. I am the director of epidemiology and fight against diseases in the Ministry of Health in Congo, and I'm also the director of program FEPT, and I'm also the chair of the technical committee in the coordination center, the regional coordination center of CDC Africa for Central Africa. So it's a great pleasure for me to co-moderate this very important session as far as emergency in public health is concerned. And without wasting any time, we are going to introduce to you the third panelist. We are talking about Dr. Peter, who's an epidemiologist, a medical epidemiologist in Global Public Health Solutions. It's a firm in public health that is based in Georgia, in America. Is also a founding member of Public Health Solution Africa. It's a reflection group that focused on public health issues in Africa. It is also one of the founder of AFENET. Dr. Peter has 25 years of experience in public health in developed countries and even in developing countries. He has spent many years in CDC America as a medical epidemiologist, supporting the creation of a training program of the workforce in public health. So we are going to give the floor to Dr. Peter for his presentation. And it will be about a reflection concerning the surveillance framework and the tools for detecting future outbreaks. Dr. Peter, you have the floor. And because we are a bit late, you have 20 minutes. And if you can spare 5 minutes, it will be a good thing so that you can help us to have some discussion. Thank you very much. Dr. Peter, you have the floor.
Thank you very much, My French comes to me occasionally, so I didn't know whether he was thanking me for the end or the beginning. I'm pleased to be here. My name is Peter Nsubuga. I'm pleased to be seeing colleagues. There are people who I haven't seen for a long, long time. I'm also pleased to see students that I taught and graduates and people doing great things, and I'm happy that I was invited and managed to come here. So I'm going to talk about surveillance frameworks and tools to address future epidemics. That will be my outline, and we'll run through some of the things. I know we have students here, so some of the things may be things you already know, but I thought that we'll go over them. So these are the main messages. In Africa, IDSR is the public health surveillance system that we use. And if we have robust IDSR, we will have we will have prompt detection and response to public health threats. And FETPs and FELTPs are critical for the proper functioning of IDSR. There are some lessons to learn from our experience. The One Health approach is essential, and any new technologies should be built on IDSR. So I ran through a bunch of things, but these are the main embedded messages. So Africa has had a lot of epidemics. We continue to grapple with them. And in this presentation, we will go through some of the issues, the challenges, and some solutions, and also talk about what we can use in the future. Now, a long time ago, I was in charge of developing field epidemiology training programs in Africa when I was at CDC. And around 2008, we came up with these critical outcomes. I think we published them, but I still need to look. And we said that if a program is working well, that within 5 years after the first cohort, we should have functional and robust public health systems, often beginning with notifiable disease surveillance and then non-communicable. We should have prompt and effective response to public health emergencies, including outbreaks and other public health events. We should have a culture of evidence-based decision-making in public health, where programmatic decisions are made on scientifically sound data. And then we should have a strengthened and motivated public health workforce comprising all parts of the FETP pyramid. And then when people come to evaluate, they should see that the program has contributed to a trend in the reduction in morbidity and mortality from priority diseases. So we talked about that in 2008, and I think a lot of the programs are old enough for us to be able to see that. So public health surveillance is something that we all care about. Steve Thacker used to be Scott's boss. Scott was my boss. Steve Thacker taught all of us. And I think we published this with him in a certain book, that surveillance is the ongoing systematic collection, analysis, and interpretation of data essential to the planning, implementation, and evaluation of public health practice. But the most important point is that surveillance is closely integrated with timely detection for those who are responsible for preventing and controlling disease. And Bill Faggy, who also used to be at CDC, and then went to Gates, said that you can't collect data unless you have something to do with those data. If you collect data for just the sake of collecting data, then you're just quantifying misery. So there are some definitions which I won't go through, but I've put here, and you will have the presentation for you to go through. And these are the characteristics that we all know of an effective public health surveillance system. It should address important health events. It has case definitions and a logical flow. It leads to meaningful and effective public health actions based on the data. It's uncomplicated, it's adaptable, people participate in it, and all these other characteristics that when we are in an FETP, we ask you when we're talking about surveillance. And public health surveillance is linked with public health response, and that you need competent people at all levels of the health system. And you also need public health lab networks, resources, and then you need to evaluate the system to inform and improve it. Scott and I wrote this a while ago, and it talks about the linkage between public health surveillance and public health action, and talks on the left side is the components of public health surveillance. On the right side are the components of public health action, and then those systems need to be supported. Now, IDSR, I'm going to spend some time on it, because this is the system that we use here. Began in 1998. We did the first assessment in Tanzania. I was pleased to be in Tanzania last week to reflect on some of those things. And the current version includes non-communicable diseases. It's meant to strengthen district-level surveillance and response, integrate it with lab support, and then translate those data into timely public health action. IDSR is the framework for the revised international health regulations in Africa. And IDSR at the bottom of the slide has two main channels: indicator-based surveillance and event-based surveillance. And indicator-based surveillance is a systematic collection of and analysis of structured data from various sources. And event-based surveillance is organized capture of information from events with potential risk to public health. I don't think you can see this well, but if you could, IBS is on one side, EBS is on another, and they lead to early warning system and response, and that is what IDSR is. And hopefully you can study that when you get the presentation. Now, this is an important slide that I got from my colleagues in WHO. It's important, it's also frightening. On the left side of the slide, it talks about weekly reporting, that 35 countries out of 47 had reported, 62% timeliness, 74% completeness. But I think the message is on the right side where we see this African map, and we see that the countries that are in green are the ones that sent data consistently, at least by June. But several of the countries here in this room are in the ones that send data but not consistently. And some countries stopped to share, and I think I had some people from there. But what is quite shocking, and this slide is important for some work that we have been asked to do, one major country in this room, on this continent, does not send data to WHO and has no weekly reporting system. And therefore, when threats come, you're going to miss them if you don't have the surveillance systems to report. We have challenges in surveillance, data collection, data sharing, and of course the resources. But I think we are beginning to address the trained personnel. So now let's move on to technology and surveillance. So leveraging technology, including mobile solutions, as we heard, everybody has a cell phone, can enhance data collection and analysis, and will improve the effectiveness of surveillance efforts. However, there are some issues with data privacy and ethical considerations, and you have to be careful. How do you balance surveillance with privacy? And how do you get informed consent and things like that? Now, I'm pleased that my colleague asked about AI, and I said, he has saved me a full slide. So how do you leverage AI and machine learning? So key benefits of AI and machine learning: we can get rapid data analysis, we can get predictive modeling, we can get image and pattern recognition, and then we can optimize how we allocate our resources, again, using AI. But there are some issues there are some challenges and things that we have to consider. Again, ethics, data quality. When an AI system tells you something, there's a tendency to believe that it's the truth, when it actually could be wrong. We also need to be trained. And then also there's an issue about equity. So how would you build a surveillance framework with AI? We need to collaborate with partnerships between governments, healthcare organizations, and tech companies. We need data sharing and interoperability. Of course, there's going to be continuous learning. AI is changing all the time. And then we need transparency and accountability so that we know why we are collecting this information and then account to the people who send the information. It wouldn't be me if I didn't give you some case studies, because this is what we do when we teach, but it's just one slide on each. So COVID-19 in Africa, COVID-19 is still ongoing. What have we learned? The importance of rapid global information sharing, the role of technology in monitoring and tracking, public health measures such as social distancing and masking, and then the whole issue about vaccine distribution and development and distribution. How do those lessons come to our experience in Africa in the future? So we need to strengthen our healthcare systems and make sure that they have access to technology. We need to prepare for vaccine distribution because there will be another pandemic. We need to promote public health awareness and education. And then we need to remember the importance of early detection and containment. What about Ebola? 2014 to 2016, we had the large Ebola outbreak. What did we learn from that? That rapid response is critical, that we need to strengthen our healthcare infrastructure, community engagement and trust building are vital, and that international collaboration is necessary for containment. How does this pertain to us in the future? We have to have preparedness. We have to have early detection and early response. And then, of course, community involvement. I'll talk a little bit about community engagement a little bit later. HIV. Sometimes we forget that HIV has been with us. It's still there. What have we learned? Long-term sustained response is required. We have to address stigma and discrimination, and there are barriers to control. We have to provide access to treatment and prevention strategies, and that we have to incorporate global efforts in research and funding. How does that help us in Africa? We have to consider education and reduction of stigma. We have to invest in research and development. We have to strengthen healthcare systems for the long term. And then we need a lot of collaboration. Now, some issues. There is the whole issue about the health and environment. So the environment and zoonotic disease and the ecosystems are all connected, as we all know. And that we have to leverage those things for epidemic preparedness, so integrated surveillance on all fronts. We can use environmental data for predictive modeling. We've talked about the One Health approach. And then we have to educate everyone that the environment can impact us, and we need to be sustainable in our resources, in our use of the environment or interaction. There are some challenges, which you will see when you get the slide. So how do we strengthen surveillance networks? Of course, cross-border collaboration. I'm pleased that all the countries here can collaborate in language. There are also regional surveillance.
Au niveau des archives de surveillance, j'étais ravi de voir mon collègue Kobil dans la salle ici. Comment faut-nous renforcer les réseaux?
Stick labs, they are indispensable in identifying. He told it to me in French and then in English. So we need laboratory strengthening, and they have all sorts of roles, and we have challenges. And then community engagement. Here I'll spend some time. I think involving communities will enhance surveillance through increased reporting and community health education. And we need to do whatever we can to get the communities involved, because they will help us in early warning, risk communication, social mobilization, and of course we need to do capacity development. There are some challenges with the community, building trust and cultural sensitivity. Building capacity, we need to strengthen the human resources. That's what we are doing here. We need to upgrade labs. We need cross-disciplinary collaboration, technology integration, and then resource mobilization. And then we need also to have global collaboration. I won't talk about this because I'm getting to one thing. I need to talk about funding and resources. I think there's a pandemic fund that I've heard about and maybe we could tap into, and also learning from what the Global Fund did on HIV and TB, see if we can do this for these other diseases and outbreaks. And then resilience. So now, this is what I was supposed to talk about. And I'll talk about it in 3 slides only. So what are the future trends? Digital surveillance systems are ways to do surveillance in the future. Syndromic surveillance, early detection of patterns and symptoms for rapid response. Participatory surveillance, and then genomic surveillance. Those are the future trends that we should consider. What about enhanced response strategies? Telemedicine and telehealth, you can send a picture with symptoms and people can work out from afar what the issues are. Mobile health applications, we've talked about them. We've talked about One Health, and then preemptive interventions based again on predictive analytics. There are challenges that I've been talking about all through, and you need capacity building and equity. So as I finalize, countries need to embrace technological advancements and multidisciplinary approaches for effective public health surveillance and response. Countries need investment in infrastructure, capacity building, and collaborative partnerships. And then going back to the first slide, IDSR is our public health system in Africa. Robust IDSR will enable prompt detection and response. FETPs and FELTPs are critical, and there are lessons to learn from our experience in various outbreaks and epidemics. And any new technology should be built on IDSR. Thank you very much.
Merci beaucoup, Docteur. Thank you very much, Doctor. We are now going to listen the last presentation of this panel. That presentation will be made by Dr. Taylor. Dr. Taylor is a principal technical advisor of the Secretariat of the Set 17 Alliance, Save Lives to Serve Lives. He's a graduate of Johns Hopkins University with a master's degree in international public health and epidemiology. His expertise in world health strategies, partnerships, and data analysis have been determinant in his career as a specialist of data and public health at the headquarters of UNICEF. He has got out of expertise and experience. He was a consultant in different institutions. So we are going to give him the floor so that he may talk to us about the progress in fast-tracking the initiative 771 in the fight against epidemics in Africa. Dr. Taylor, you take the floor.
All right, good morning, everyone. Good afternoon now. Bonjour. Habari Asabuhi. I'm going to keep going until we get everyone. Sabah al khair. Anyone else? Bom dia. All right, good. I'm glad we're ready because I'm running out of languages. All right, there we go. Okay. I'll be quick because I know that I'm the last presentation today, and I'm sure we're eager to remove ourselves from our chairs and network and visit other sessions and take bio breaks and all the great things that we get to do after this. But I want to thank you first to the AFENET conference organizers. This is actually my first time attending the AFENET conference, and it's been truly a pleasure to get to meet so many new people and have the opportunity to learn from some of the brightest minds in global health security. So I'm thrilled to be here and humbled to be a part of this great panel. So today I've been asked to speak on 717. Some of you may have been involved in adopting and implementing 717 in your countries. Some of you may have colleagues who are advocating for 717 in your countries but aren't yet sure what it is. And others of you may be new to this and are just hearing these three numbers in various presentations and discussions over the course of this week. So we're going to talk a little bit about what it is and what the future for 717 implementation and scale looks like. So what is 717? A simple set of timeliness metrics. It has corresponding targets, and that helps jurisdictions, countries, counties, states to be able to identify bottlenecks and then propose actions to mitigate those bottlenecks. And in doing so, it presents an opportunity to improve epidemic preparedness and response. The 717 target includes 3 timeliness metrics, which you'll see along the slides here in red, yellow, and green. The first is around timely detection. That's 7 days from the emergence of a suspected threat until the detection of that threat. It's then less than 1 day from detection to notifying the appropriate public health authorities, and then it's an additional 7 days to initiate an effective early response. This is where the 7, 1, and 7 come from. So we know that every outbreak is unique. The nature of the disease, the geopolitical, the sociocultural context, the strengths of the health system and the health workforce all cause variations in different outbreaks. But often the challenges and the bottlenecks and the constraints that we have in responding to them are very similar. And so 717 was developed based on the idea that we shouldn't have to keep addressing the same problems over and over and over, and that every public health event is an opportunity to learn and improve. And the idea that a simple set of timeliness metrics could help countries to identify the bottlenecks and actions to address those bottlenecks. So right now, the main mechanisms we've had to review performance for outbreak response are the intra-action review and the after-action review. These remain essential and critical tools. With the intra-action review, we have the opportunity to learn from the event during the event so that we can course correct. But this is often implemented only during ongoing and protracted responses. The after-action review provides an opportunity to learn from the event after the outbreak has been declared over. And it's also typically only applied for larger scale outbreaks. And so we ask ourselves, if every public health event is an opportunity to improve and to learn, then what about those that don't trigger an intra-action review or an after-action review? And what can we do to learn from the event and improve the response in real time instead of waiting until it's over or nearly over? This is where 717 comes in. So the 717 target is now adopted and is the bedrock of the new normative guidance from the World Health Organization on early action reviews. These early action reviews, using 717, create an important opportunity for real-time and rapid performance improvement in the earliest phases of a suspected outbreak. So, how does it work? There are different approaches to implementing 717. There's a real-time review of a single event, which is your typical implementation for rapid performance improvement. You have a retrospective review of a single event, which can be complementary to an after-action review. And you also have the retrospective review of multiple events. So this last one comes from the idea that if your country is interested in adopting 717, you shouldn't have to sit around and wait for an outbreak to happen to start using it. So what we've seen many countries do, and it's proven to be very valuable, is when 717 is adopted, one of the first things you do is collect historical outbreak data from outbreaks that have happened over the last 6 months, 12 months, 18, 24 months, and do an assessment on those outbreaks in aggregate. And this will help you to identify some of the common bottlenecks, the common constraints, so that you can begin to address those immediately without having to wait for an outbreak to occur. But regardless of which three of these implementations you opt for, and they're not mutually exclusive, it's usually some combination of all of them depending on the nature of the context, the steps are more or less the same. We're capturing timeliness data. We're using that to calculate 717 performance. We're using that 717 performance to conduct a bottleneck analysis and identify gaps, and then identifying and implementing corrective actions to those. So let's look at a real example. We have my colleague Lydia here from Uganda, who is an absolute expert in this. Uganda, and I'm sure many other colleagues here from Uganda were a part of 717 as well. Uganda was one of our earliest adopting countries, implementing 717 and piloting it starting over 2 years ago. So when the Sudan Ebola virus outbreak occurred in Uganda, the 717 approach was used to assess and improve the response during the response. It's a little difficult to see this slide, so I hope you have the opportunity to review it when you receive a copy. But essentially, the 717 found that it took 46 days to detect the outbreak, less than 1 day to notify, and 9 days to mount an effective early response. So they found that the largest delays were from outbreak detection, and there were some additional delays on the response as well. So they conducted a bottleneck analysis to get to the root cause of these delays, and they identified enablers to the system, and they suggested corrective actions. Based on this analysis in Uganda, during the outbreak, the government was able to quickly identify partners with available funds to reduce delays in accessing rapid response team funds for contact tracing, and also identified new buildings for an isolation unit, since the previous infrastructure was deemed to be inadequate. They also identified a longer-term priority, which was to increase IDSR training, specifically at private facilities. So this example from Uganda demonstrates how 717 can be used for rapid performance improvement. But we've also found that it can be a very effective tool for prioritization, for financing and system strengthening initiatives, for communication and advocacy. It's data-informed and data-based, but it's also simple to communicate, and that proves to be very effective, especially with senior political leaders. And it's also useful for accountability and reporting. So the added value that we've seen from 717, based on the initial early adopting and piloting countries, is that it complements the existing health security frameworks. It helps find system-level bottlenecks, enablers, and actions. It emphasizes the need to take prompt actions with clear metrics for all outbreaks, and that it identifies actions for continuous quality improvement. So, where we are now. As results have been published and shared, 717 has been generating a lot of interest from countries, as well as it's also being adopted and integrated into global frameworks and regional strategies. Here in Africa, WHO's Afro-Regional Office has adopted the 717 target in the Regional Strategy for Health Security and Emergencies for 2022 to 2030. And in that, it includes an indicator to have all 47 member states meeting the 717 target by 2024. All 47 by 2024. So as a result of this and other examples like it, we're seeing significant demand from countries, as well as from regions and continents and across the globe, to expand our scale and support additional implementation of 717 globally. So where is it being implemented now? 717 was originally piloted in Uganda, Nigeria, Ethiopia, Sierra Leone, Rwanda, Liberia, and select subnational areas in Brazil and the United States. Other countries that have recently adopted and begun to use 717 are Zambia, South Sudan, and Cambodia. And we're currently working with a handful of countries to adopt and begin planning and preparations for implementation, including in the Democratic Republic of the Congo, Mozambique, Pakistan, and the Kingdom of Saudi Arabia. And there's interest from many, many more. So in order to support the scale and this significant demand that we're having for this, the 717 Alliance was created. So the 717 Alliance is a country-led initiative to support countries to adopt, use, scale, and sustain 717 in their workflows. To do that, the Alliance has made some resources available. We have a technical steering group that guides our strategic direction. This region is represented by Dr. Issa Makumbi from Uganda and Dr. Elsie Ilori from Nigeria. We have a team of technical advisors that can provide direct technical support. We have launched a grant mechanism where we can offer catalytic grants in different sort of buckets of funds. There's one around country adoption to help countries to get the stakeholder buy-in and get the integration. There's one around rapid performance improvement to help resolve and implement some of those corrective actions. And then there's another pool of funds around operational research. So there are catalytic grants that are available. We've been forming institutional partnerships that help our small team to be able to scale technical support to many countries in many regions, as well as to support operational research. And we've launched communities of practice and global and regional learning networks with the idea that sometimes the best way to learn about what to do in your context is learn from the examples of others. And through this, we've also created like site visits where like the team that was planning to implement in South Sudan did a country learning visit to see how it was implemented in Uganda to get direct on-site learning experience from them. This map shows the status of 717 adoption among our countries that have formally signed a partnership MOU. So you'll see in green the countries that are a part of the alliance that have adopted this at national scale. In orange, the countries that have adopted this in select subnational areas. And in blue, some of the next countries that are beginning to implement. And I know some people out there are rightfully looking at this map and thinking, où sont les pays francophones? We do have DRC starting soon, and we're beginning to have discussions to implement in a couple other West African countries, but it's a priority for us to expand our implementation and examples to other Francophone countries as well. And one of the main ways that we'll do that, Dr. Virgil on the opening session mentioned the partnership with WAHO, which we're looking forward to being able to launch soon. And we anticipate that this map will be significantly more filled in the next time that you see it. So in this room, we have some just incredible leaders and experts in this field. And many of you already are or are going to be implementing 717 in your countries, and we would like to support you and we would like to work with you. So how can you join the alliance? How can we support you? How can we connect? If your country is interested in becoming a formal partner of the alliance, you can go to this. I got almost done. Yeah, it's like 2 slides. Yeah. If your country is interested in becoming a formal partner, you can reach out to us at the email address there. It's contact@717alliance.org. If you personally are interested in subscribing to get routine updates and news and notifications, as well as opportunities to participate in some of our learning webinars and training series that will be coming out over the course of the next several months, there's also a subscribe option on the website, which I'll direct you to in a second, so that you have the opportunity to subscribe to that and have personal invitations to many of these upcoming events. Speaking of those Global Learning Network webinars, next week we actually have a very exciting one where we will be talking about early action reviews and the rollout of those. So Dr. Stella gets her second shout out during this panel session, as well as Dr. Landry will be joining us from WHO to talk about the implementation and rollout of the early action reviews and how 717 is being used for that. So if you're interested in this and subscribe to the Alliance, we'll make sure that you guys have an invitation to participate in that webinar. Finally, all of this plus additional resources to support implementation are available on our website, which is 717alliance.org. We have materials and resources available in multiple languages. And I also brought with me, I'll take advantage of the platform that I briefly have. We have some informational sheets in English and French that we can set out maybe over on the stage or over here if you want to grab any of those, as well as some 717 Alliance business cards. And those have different URLs and QR codes. So if you are interested and you pick up some of those materials, you'll be doing two things. One, you'll be gaining access to all of our information as well as easy means of communication to reach out so that we can see how we might be able to support you in your efforts around 717. And you will also be making my carry-on significantly lighter for my 3 flights home, where I will be embraced into the good graces of my communications colleagues. So that's it for me. I want to say thank you, asante ni sana, and appreciate this opportunity. Thank you.
Merci beaucoup à tous.
Thank you very much to all. I think according to our program, we won't be able to answer to questions, but if you don't have a question, we do have panelists. They will answer to your question. So we saw the presentation from Dr. Peter will talk about surveillance and how to consolidate surveillance of public health. And it says it's not just a matter of collecting and analyzing data, but how to use them and set up appropriate actions so that we can improve health of our population. The second paper, or the last one, was by Mr. Taylor, who talked about the WHO Initiative 717. And if we can summarize, the initiative is about how to detect a pandemic with 7 days after it has been signaled. So if it can be done within 24, 48 hours, that will be even better. And then we should be able to notify and come up with appropriate action to intervene. So we are going to thank all our panelists for these topics, because as you know, Africans have a lot of pandemic. We have more than 100 in Congo. We had about 5 last July. We had 3 within one town. So that is a current issue, and we will we are happy to talk about it. Thank you very much for your understanding and your participation. So we are going now to give the floor to the organization for the rest of the program. Thank you very much. We can clap. Please clap for the panelists as well.
The concurrent session before lunch. We are a little bit behind time, but we are hoping that the various moderators will regulate the time in the various concurrent sessions.